guys, Dr. Swarbrick. I'm going to wrap up modules 11 and 12 regarding medications in relation to seizures and how to manage an acute seizure with diazepam, for example, which is benzodiazepine, or folks that have chronic seizure disorders, also known as epilepsy, in sense of managing and decreasing frequency of seizures. So if you have your farm book, if you want to download this Word document, if you want to highlight and take notes as I go, whatever works for you. I apologize, my emails are kind of bouncing around. So basically on chapter 12, we're starting with some of the more traditional and or anti-epileptic medications or AEDs. And as I mentioned in class, I really want you to focus on phenobarbital. And I also want you focusing on phenatonin. Phenobarbital, as I noted in class, we have to be pretty careful in the sense that it causes drowsiness and sedation. So I would recommend that this drug be taken at bedtime if at all possible, or if it's a double day type of dose or BID, the smaller dose in the morning hours and that larger dose in the evening. So to kind of reduce logically patients' ability to have quality of life during the day without being overly sedated. Do know that it can cause confusion and anxiety in the older adult. So pretty much, I mean, basically what I would focus on, because of the CNS depression, we have to be mindful of fall risks, obviously with seizure disorders, avoiding other types of medications, food and alcohol that can cause increased depression, CNS depression, sleepiness, inability to be focused and alert of that kind of nature, such as driving. Can cause physical dependence. Toxicity can be considered ataxia, hypotensive depression, coma, pinpoint pupils. The biggest thing to recognize, as I mentioned in class, is certain kinds of vitamins, specifically vitamin K, which is your antidote for Coumadin, and vitamin D will decrease the effectiveness of Coumadin. Coumadin is an anti-coagulant that we use specifically for atrial fibrillation. We also use it for folks that have heart valves, even though there's a newer medication called Eliquis that will treat or reduce AFib clotting mechanism secondary to heart valve replacements. Folks with DVTs or histories of pulmonary embolisms can also be on warfarin. In the community, they just have to have their blood levels, PT and INR, drawn to ensure that we're clotting in a timely fashion. So A, the blood's not too thin, or B, the blood's not too thick. So be mindful when you're doing a medication history that you're looking at those things specifically, especially if they have an underlying seizure disorder. As noted, as I mentioned again with the phenatonin, it can cause double vision, sedation, cognitive impairment. So it has similar CNS effects of your traditional anti-epileptic medications because it's sitting there in that specific classification. So am I having you look at more than one prototype? Yes, I am, because Dilantin has two specific underlying concerns that we need to be educating our folks for. One is called the gingival hyperplasia, which is an overgrowth and softening of gum tissue, and therefore tenderness and bleeding gums. And so as we talked about it in class, we really want to educate these folks and their families on soft bristle toothbrushes, notifying the dentist prior to dental care, flossing, things of that nature, so we can maintain the integrity of our oral cavity. The other is the skin rash. It has to be stopped immediately. You can have cardiovascular effects such as arrhythmias, dysrhythmias. Someone could be hypotensive. I will tell you that I also have on here carbenzapine, which does treat bipolar as well. But some of the bigger pieces with carbenzapine is that it has an ability to treat specifically tonic-clonic seizures. And if you write the carbenzapine down on a separate piece of paper, I want you to write down the acronym of Tegretol, because what it does is it inhibits the nerve impulses by limiting influx of sodium into the brain. So by doing that, all these excessive electrolytes and bursts of transmitter electrical storm, and we'll use it for tonic-clonic seizures, complex partial. We'll also see it used in trigeminal neuralgia. So that can also feed back in some of that peripheral neuropathy that I spoke to yesterday, including diabetic neuropathy. And you may see it ordered to treat bipolar or mood disorders. It is an alternative to lithium or valproic acid, which I'm also going to talk about. We will not use it for folks who have histories of glaucoma because it can increase intraocular pressure and can be hypersensitive to having more problems with what's the word I want? Increasing the risk for IOP. You also have to be very, very careful with carbenzapines, specifically to ensure that these folks are assessed for liver function tests, which we would do anyway. But the reason I'm bringing it up is that your liver is responsible for production of platelets. And so with platelet counts, we have to be making sure these folks don't have spontaneous nosebleeds, spontaneous bruising, because that tells you they're not coagulating or they're not making platelets. So we often have to make sure the liver function test, not only from a metabolic state, but the other pieces of what the liver is responsible for making and managing in our body. You also want to be mindful that we're also going to always start with a low dose. Again, you're dealing with electrolytes and neurotransmitters, as we talked about with mental health. Again, as I noted with phenobarbital and even dilantin, best time for carbenzapine is to administer the largest dose at bedtime. So the sedation will maybe improve sleep deprivation, but the bigger piece is not to have it so sedative during the day where you have a quality of life interaction. So the Tegretol for carbenzapine, the T is going to be treatment of tonic-clonic seizures. The E is you always want to be evaluating for nausea, dizziness, headache, sedation, sore throat. I know that sounds sort of across the board throughout, but more so with your carbenzapines, do you have a GI upset factor built into that? So we have to be pretty clear on how it manages the liver from a platelet count, the GI system. We want to give it with food or milk to reduce the GI disturbances. That's the G. It does require blood work, so we have to review levels and maintain the therapeutic level. I'm not going to test you on that, but you do need to know that if someone's on carbenzapine or Tegretol, that lab work is required just as it's required for dilantin. You want to evaluate for anorexia, and the reason behind that, I'm not talking the mental health body disturbance of anorexia nervosa. I'm talking about the increase of nausea, the GI disturbances that can cause somebody to not want to eat, not be hungry. And also anorexia of not wanting to eat can relate back to toxicity of the drug. So we need to have frequent lab work. It's a chewable for tea for tablet. So we don't swallow whole, we chew the tablet. And we take the extended release capsules whole, no crushing or breaking, and that goes back to your 117 days. The O is for open, mix it with food, extend release capsules will be extended over a period of shelf life and how those chemical compounds within the mechanism of action will work throughout the body. And L, you want to look, they have many, many, many drug interactions. So the biggest piece of this is to make sure that they're taking it with food. Enteric coated may decrease some of those GI manifestations I mentioned. We have to be pretty clear and comfortable in looking for Stevens-Johnson syndrome, which goes back predominantly to the skin rash for phenatonin. So you're within the family of antiepileptics, traditional AEDs, antiepileptic disorders or drugs. So you have your phenobarbital, your phenatonin, your carbenzapine, and then I'm going to talk about valproic acid, which will treat bipolar as well as migraines. Valproic acid has more of the GI effect, so it's got more of the nausea, vomiting, indigestion. So again, you want to take it with food. If it's offered through an enteric, it'll bypass the stomach and digest in the small intestine. Remember, your 117 days with enteric coated, we don't crush, we don't split. It has more pronounced possibilities for hepatic toxicity or liver toxicity. So what are these folks going to look like? They're going to look jaundice, so white of their eyes or the sclera, abdominal pain and anorexia. So again, you're assessing baseline liver function tests on these folks and monitoring them periodically. We don't use it with children less than 2 years of age. We always go, again, lowest dose possible and then kind of follow accordingly. For valproic acid, I'm going to give you another acronym. It's going to be Depakote. So D is going to, let me just back up. When we talk liver toxicity, we talked about the jaundice potential, so yellow skin, sort of a yellow hue to the skin, because the body is trying to get rid of the bile, and the bilirubin's building up in the bloodstream. The other thing that's building up in the bloodstream is ammonia. Liver is a metabolizing agent, so it takes any types of foods, alcohol, drugs that have a byproduct of ammonia, which has to be wasted. So when the liver is not functioning, ammonia levels will build up in the bloodstream. So D is to discontinue immediately if you have elevated ammonia levels. And that looks like what's called hepatic encephalopathy. And you talk about that chronic-wise in 211 as it relates to cirrhosis. But liver disease from alcoholism will cause a cirrhotic liver. And so these folks are at higher risk for elevated ammonia levels. What happens in these folks when you have elevated ammonia levels in the brain, you have increased mental confusion. You can also chalk it up to the word delirium, that they're alert and oriented, and then elevated ammonia levels changes that baseline cognitive presentation. And if they're on valproic acid, we should be getting some LFT levels on them to make sure as well. The E stands for increasing levels of GABA in the brain, but the GABA levels is what decreases the seizure activity, because most of your anti-epileptics, their mechanism of action is GABA, GABA, and at the moment, I'm not going to get that GABA for you, but understand it's a neurotransmitter, and it has the opportunity to decrease seizure activities. So it will cause elevated levels. That's an expected finding. P, prolonged bleeding if given with antiplatelet agents, and I talked about that as it relates back to carbenzapine. A, avoid your CNS depressants. Don't give with carbonated beverages. Don't give with alcohol. So the COTE, the COYOTE, can be, somebody can be manic. And here's the thing with the carbonated beverages, if they have caffeine in them, the treatment we can use valproic acid or Depakote for is the treatment of migraines. So migraines with high doses of caffeine can really help alleviate migraine activity. So you don't want to add caffeinated beverages to the valproic acid. It's going to increase the shaking and how people feel when they're on too much caffeine. How does that work? So again, your undesirable effects are that confusion, that sedation, liver toxicity, the rash, the prolonging bleeding time. So go back to your physiological understanding of the roles and responsibilities of your liver, besides storing bilirubin and or making bilirubin during the digestive process. It does platelet counts. It manages red blood cell production. It manages wasting of pneumonia levels. It manages glucose levels. It has a huge responsibility when you start destroying it, for example, with underlying chronic disorders, and they have a seizure disorder, then maybe this is not the right medication for them. It also can cause pancreatitis. So be mindful of that. And then we also want to make sure we're keeping an eye on platelet counts, as I noted, and bleeding times. Being mindful, the word for low platelet counts is thrombocytopenia. And therefore, when you have someone with a low platelet count, you're putting them at high risk for spontaneous bleeds. So here's another example of patting the bed, soft bristled toothbrushes, making sure they have a steady gait, keeping an eye on spontaneous bruising, nosebleeds. You don't have the platelet count to coagulate or to make platelets, okay? And hyperammonia is incredibly important to be mindful of. So I can't stress that enough. The newer anti-seizure medications is the gabapentin, as I mentioned yesterday, in the peripheral neuropathy voiceover. It has an off-label use that can help treat peripheral neuropathy. So just give me a minute and I will find my fun facts for you. So think about something fun. I think I have it on 380. All right, now I gotta look it up. So bear with me. Uh, so just start singing the Jeopardy stuff. It's not really noted in your ATI book per se. Gabapentin. It's on the bottom of chapter 12 or page 100. Let me just look up a little bit more information so I can give you a little bit more. I mean, ATI has wonderful resources in the sense of what it can focus on, but it's not real good, in my opinion, when it comes to particular pharmacology. So I do use in a separate book called Pharmacology Made Insanely Easy. And you can get it if you want, but if you're an acronym person or a mnemonic person, then this is the book for you. I used it for most of your cardiac meds, your 3 voiceovers for cardiac meds, and I've used it for module 11 and 12 in previous courses. I don't use it in the first 5-6 weeks of the course because I do feel that your ATI pharmacology for upper GI, lower GI, and renal, as well as mental health, does a good job in pointing out factors in managing safe patient care. But I did not feel that it did a big job with that. So neurotin is not really fully understood. It helps with the synapses in the sensory motor nervous component. You can use neurotin in therapy for partial seizures, ALS, multiple sclerosis, peripheral neuropathy. As I said, the unlabeled use is the neuropathic pain, so you might see it there a lot. Not really recommended for women who are breastfeeding, as hypersensitivity to lactation. The acronym that this reference that I'm using is Caesar, CAESAR. So the C is the CNS depression. Excuse me, CNS is dizziness and insomnia. Um, A is that if they take it with antacids, Tums, Rolaids, it will decrease the effectiveness of the gabapentin. You do want to take it with food just to reduce GI upset. I think with any medication that is treating seizure disorders or epilepsy, support groups should be important. And even though it's noted in this mnemonic, I think it's just kind of across the board because we talked about the anxiety and the depression and the social observations of people who, for example, might have the gingivitis, gingival hyperplasia. People with seizure disorders should wear alert tags, especially if they're diabetics and they have, or seizure disorders, because if they're found unconscious, that's your communication for EMS or somebody coming upon not witnessing a fall or someone being unconscious. And we definitely want to be mindful of evaluating, definitely taking with food and treating it for epilepsy. And again, the off-label use is peripheral neuropathy. So what your book kind of does speak to is just to be mindful of ataxia, which is an unsteady gait, or I think ataxia is unsteady gait, or a kind of a stumbling gait. Fatigue, nystagmus is not double vision. It's where the eyes come in to the bridge of the nose, I believe. Peripheral edema, but it should diminish in time, and avoid anything that requires alertness. So, avoid driving and working with heavy machinery. And that's kind of all the book talks about for ATI. So again, Made Insanely Easy. I don't promote the book. I'm just telling you where I'm getting my resources from. So of course you can always stop and start as you move through this particular voiceover for medication. I will tell you, Muscle relaxants and antispasmodics. Muscle relaxants, your benzodiazepines. You want to reduce the chaotic electrical conduction in the brain, because seizures disorders that go beyond that 5 minutes will continue to cause brain damage. This is not, I mean, epilepsy is a serious chronic disorder that, due to congenital birth defects, due to hereditary, due to traumatic brain injuries, due to hepatic encephalopathy with permanent brain damage. The underlying cause is important, but even though you've identified the reason why someone is epileptic, we still have to drive the bus, because really the management of care is pharmaceutical community support. But unless we can quiet down that abnormal chronic seizure electrical conductivity with these type of medications, then it's a real problem, because patients can lose any neurological function, and that affects obviously quality of life, not quantity, but quality of life. Be mindful with your seizure medications in general. We have to be very mindful with our pregnant people, that if they have a epilepsy disorder, that they need to be very specific with their OB, because some medications do cross the well, I'm not an OB, I'm not a L&D nurse, the into the fetal uterine lining. Medication can get in the baby's bloodstream, and so there has to be monitoring of medication administration, what meds to use. Pregnant people will be at higher risk for seizure disorders during pregnancy, with the hormonal changes, things of that. So they become high risk. Mom has a seizure. You remember, you're going to be oxygen deprived and you're going to be glucose deprived. So your fetus is going to have oxygen deprivation and sugar, which can cause all kinds of unfortunate not birth defects, but developmental delays, etc. So that's kind of where I'm at. I think that kicks the highlights of what I consider safe management of care. Let me stop sharing my screen for a minute and make sure that I've got all the medications that were on here. I'm missing glaucoma. All right, so let me share my screen again. Bear with me, because I'm not the best doing this. So why don't you do this instead of me kind of going on and on about it. Pull up your Word document in Module 12. You can pause me, and then if you want to just copy and paste we're going to spend some time on the eye disorders from Module 11. And again, I don't feel that the eye disorders were very well managed pharmacologically with ATI pharmacology, but the eye disorders is noted as in Chapter 13. And so what I want to do is just pause me so that I can speak to a little bit more with this book that I really, truly enjoy. So as I noted in class, Timonol is a non-selective beta blocker. And non-selective basically means, if I could spell and read at the same time, might be good. So when you get to beta blockers, and if you've had time to think about, well, that's not fair of me, I apologize. If you've had time to listen to the beta blockers for hypertension treatment, and granted, we're not covering that until a week from Tuesday, but your laugh out loud meds are beta antinergic blockers. So what they do is, your beta 1 is your cardiac, and your beta 2 is your lungs, and the beta is enzymes or hormones that beta 1 works specifically in the heart, and beta 2 specifically works in the cardiac and the lung. So we have to be very mindful that it's decreasing contractility for the heart to help reduce blood pressure. It works in the kidneys to decrease an enzyme called renin that also can cause hypertension. And so when I say that Timonol is non-selective, it's neither beta 1 or beta 2. And Timonol is only used as an eye drop. So therefore, you're not going to get necessarily the systemic hypotensive type pieces, and you're not going to get the bronchospasms associated with beta 2 antinergic blockers. So just to reiterate, you've got folks with COPDs, underlying pulmonary conditions that are chronic. You're not going to give them a beta 2 to manage blood pressure because you're going to put them in bronchospasms. However, so definitely don't put them with your COPD patients, your asthma patients. Just be mindful that it's decreasing the contractility in the heart and the renin. But Timonol is systemically, administered as an eye drop to reduce intraocular pressure. And Timonol is lifelong because without it, your patient can go blind. And being blind is permanent. But it treats that, open angle glaucoma, which is the one that's slow to progress. It's the non-emergency one, as we talked about. They can occasionally, but it's not in long-term management. It can cause a stinging discomfort initially, and you want them to report conjunctivitis. So ask yourself what conjunctivitis is, and ask yourself what blurred vision. Photophobia, again, is sensitivity to sunlight, and they may develop dry eyes. I'm not going to say it's an adverse reaction to Timonol, but I am going to say it's an uncomfortable reaction. And if it doesn't resolve, I hate the word non-compliance, but you're probably not going to get the buy-in of the patient to take it. So therefore, that's going to increase the risk for blindness. So even though it's non-selective beta 1 or beta 2, it's still a beta blocker. So we still have to be mindful of cardiac conditions. So with laugh out loud meds, not only do they help manage hypertensive patients, their expected side effect is to cause bradycardia or low heart rate. So we do have to teach our patients with glaucoma, and we'll talk about laugh out loud meds when we talk cardiac, is that they need to check their heart rate. Now, as I say to students in simulation, we're the ones who can check the apical heart rate because we're trained to hear it with our stethoscopes. It's perfectly okay to teach your patients to do a radial pulse, but that's a teach back and that's a demonstration. So I suggest you do a radial pulse on the left arm and then you teach your patient to do on the right, and you get out your watches and you count so that you can make sure that they are counting correctly, and you want them above 60. And obviously use more cautiously with folks that have underlying respiratory complications and other things. And let's just leave it at that. So we're not driving a different kind of boat. Pregnancy has not been established. Definitely would talk about breastfeeding. I've already talked about not using beta 2 blockers who have chronic respiratory disease. And, if we have someone who significantly has bradycardia or heart block, Timonol is not going to be the drug of choice for these folks to treat their glaucoma. So I'm going to leave this piece to you because you're going to need to go back into your 117 eye drop conversation with your instructor at that time. You instill 1 drop in the infected eye once or twice daily based on the prescription. But you need to teach your patients what the proper way of instilling eye drops are, and make sure, again, that you're watching the patient do it, or if we have to teach a family member. And that's the same type of teach back as it is checking a radial pulse. Hold gentle pressure on the nasolacrimal duct, so that kind of helps a little bit with minimizing that systemic effect. And again, always monitoring the pulse rate. And try not to have the applicator actually touch the eye, and keep the lid in place when not in use. It doesn't say anything about keeping it out of the light. You are going to be responsible for reviewing eye drop safe administration. So next is our alpha-2 adrenergic agonists, and we're going to look at brimonidine. And this is both an alpha and a beta blocker combination. And it can be used to lower interocular pressure for our glaucoma patients. It can be used as a first-line topical treatment. So my focus is more on the Timonol because of the bradycardic cardiac complications that because it's a Maslow, obviously, in management of care with teaching back because these folks will manage their glaucoma in the community. So I want you to be very familiar with how to manage that piece of it. So there's not a whole lot there per se. You have the same type of discomfort, the stinging in the eyes, pruritus, or conjunctivitis, client education of not rubbing eyes. You shouldn't rub the eyes regardless of that nature. Always monitoring vital signs. Pilocarpine is another type of medication that can be used for glaucoma. And I'm going to if you give me 2 seconds, and again, the book doesn't do the best of jobs. Pilocarpine, pilocarpine, pilocarpine. There we go. 342. 342, and that's the page number. But I've seen pilocarpine as much as I've seen Timonol. It's a miotic, and what that means is it stimulates the pupillary and the ciliary sphincter muscles, resulting in pupillary constriction. So here's a good place where your perla, pupils equal to right, pupils equal reactive to light and accommodation. We also use it for surgical procedures on the eyes because it can be used for constricting eyes so that we can do surgical procedures, for example. So I bring it up for that. Undesirable side effects, obviously blurred vision, eye pain, headache, hypertension, tachycardia. But the myoptics piece of it is, so I'm going to spell out under the word constrict. So myotics is M as in Michael, IOTICS. So when you're looking at this, the C is where we're going to start with the word constriction. So since it constricts the pupillary, the pupil of the eye, these folks cannot have any form of atropine because atropine is a systemic constrictor. And so you want to be very, very careful that we make sure that we are assessing medications. And that's the reason I'm bringing up the pilocarpine specifically. Last but not least is your osmotic agents such as mannitol. It decreases interocular pressures as well. It can be used to treat rapid progression of closed angle. So you may see it there as well. So osmotic, on the other hand, and let me look up the mannitol that I like this book. 72. Oops. All right. 72. Sorry, guys. Or just hold on. So osmotic, such as mannitol, the reason I'm bringing it up is that you also may see it used to treat CHF. It does help with, it increases excretion of sodium and chloride, which we know sodium chloride, potassium, kidney function. So what you may see mannitol used more in cardiac as well as also for treatment for glaucoma. But it can be used as other forms, and it's an osmotic diuretic. So in that regards, people can have headaches because of some of the pressure of. Let me back up my bus. Because of increasing excretion of sodium and chloride, we have an opportunity to stop the reabsorption of water. But with an electrolyte, sodium and chloride insufficiency potentially can give people nausea, GI disturbances, and can increase intracranial pressure. So we don't particularly going to use it with our heart failure patients because that's just have a bad pump. So we're not improving circulation. You don't want to use it with folks with kidney failure. You want to be very careful with folks with hypertension, pulmonary edema. So when you're doing a reabsorption of secretion, increasing excretion of sodium, you're going to be pulling off more water. So these folks are going to be thirsty, have a dry mouth, can have blurred vision, cellular dehydration. It's not a fun drug. It has a lot of underlying components, but you may see it in your practice. So obviously interventions, monitoring renal function, BUN, creatinine, potassium, sodium, chloride, GFR. You want to do potassium levels, sodium levels, and I'm going to talk about the word osmotic here in a minute. You want to watch for a rapid increase in blood pressure, and you also want to watch for an increase in intracranial pressure. Good. All right. So osmotic. So O as in not awesome. O as in open. S as in whatever. M as in Michael. O as in O. T, T, I, and C. Not only can we use this for glaucoma because of its osmotic purpose, the O stands for oliguria, edema, and increased cranial pressure. We are going to treat increased intracranial pressure. So folks that have traumatic brain injury, have a stroke, have some form of cerebral hemorrhage, hemorrhagic stroke. I think I just said that. Ischemic stroke. Be mindful of the reason I'm pulling this forward, because when you have a brain injury, you're increasing intracranial pressure, and the only way to pull off the fluid is through an osmotic agent such as mannitol. Oliguria means limited urinary output, and not anuria, which is no output, and edema. So I'm not voiding. I'm holding on the fluid in my interstitial tissues, and I've got fluid building up in my brain where it's not supposed to be. So that's where the headache is coming from. Can't think, you can't blink. So it stops the reabsorption of water, and we give them mannitol, and that increases the output of urine, helps stabilize the electrolytes. We monitor that. We keep an eye on tissue dehydration, and we'll have an increased frequency and volume of urination. And we have to be mindful of not having circulatory overload. So mannitol is going to be used particularly to pull fluid off of the brain, but I'm adding it to the list of meds for glaucoma because it has other much more cardiovascular and neurological implications. And so since you talk TBIs and trauma in 211 and 213, you may see this medication not only in clinical practice, but part of your curriculum. So if you have any questions, shoot me an email. These are the requirements that you do need to be prepared for. But my focus really is on the Tylenol as well as the traditional anti-epileptic medications, and being mindful specifically of how I talked about or highlighted areas that I need you to be mindful of. And I think that will do it, and I will get this posted, and I'll put it in module, I'll put it with module 12. Thanks, and have a great Sunday.